So the final presentation, I'm pleased to introduce Carolyn Shimon. She's from the Center for Healthcare Innovation, Knowledge Translation Unit, and the expert in patient engagement for research. So welcome, Carolyn.
Hi, thank you so much, Gail. The expert, I'm always scared. So the concept of patient engagement in health research has received growing national and international recognition over recent years, and the Canadian Institutions of Health Research define patient engagement as the meaningful and active involvement of patients in the governance of research, in the priority setting of research, in the conducting of research, and the translation of research. And so what this means is moving patients from subjects or participants to full partners in health research. And I actually prefer, this is something that we've learned throughout engagement, is I actually prefer the term people with lived experience, because a lot of times there's questions around people as far as access to healthcare systems, geographical, systemic barriers, may not have the same access, and so they may not identify with the label patient. So we a lot of times tend to say people with lived experience, and that also opens it up to families, informal caregivers, friends, communities, elders, and so on to be involved in health research. And the whole underlying belief around patient engagement in health research is that by involving people with lived experience in health research, it'll lead to improved outcomes and an enhanced healthcare system. It'll improve the quality, the appropriateness, the acceptability, the transparency, and the relevance of research. And it'll also ensure that it addresses issues of importance to people who are living with health conditions and the people around them. At the Georgian Fahey Center for Healthcare Innovation, or CHI, we kind of work at a three-pronged level. So looking to support and facilitate the practice of patient engagement, so around methodologies, best approaches, and so on, building and strengthening the patient engagement partnerships, and then advancing the science of patient engagement. Because as you know, there is a little bit of dearth of evidence as far as best practices, and also just evaluating the impact on research outcomes, as well as impacting the integrity of those patient engagement relationships, so the impact on the researchers and the patient co-researchers. And we see it as kind of an integrative model where we have champions in patient engagement in each of our platforms, so researchers can talk to somebody around this no matter where they come from. Now, there's different levels of involvement, and this is something that sometimes a lot of researchers will go, how do I even begin to think about it? And so the Patient-Centered, PCORI, so Patient-Centered Oriented Research Institute in the U.S., and combined with IIT2, they've kind of created levels of involvement. And the first level of involvement is called the consultation level. And this is actually where health researchers kind of feel the most comfortable, I found, here in Manitoba at this point in time. And this level is working directly with people with lived experience. So this is actually, this is obtaining, so consultation is the lowest level of involvement, and so this is obtaining public feedback and input on everything from research priorities, research questions, study design, data collection, outcome measures, analysis of the results, relevance of the findings, dissemination of the findings. And the promise is we'll keep you informed, we'll listen and acknowledge your concerns and aspirations, and we'll provide feedback on how your input inform the research. So it's all about input, opinion, and the biggest thing is that at this level of involvement, researchers still have the decision-making power. An example of this would be there was an asthma study where clinicians and patients were brought together for a one-day workshop, and they were asked to provide their input on who should deliver the intervention, when it should be provided during the process of care, and how it should be delivered. And so those suggestions and input, they used a methodology called a World Cafe, and they collected that input, and it was able to inform the research process. It wasn't shared decision making, it was more it informed some of the research design, and then the participants got a feedback on how their input and suggestions. That's the one important thing, is always have a feedback loop. So always make sure your stakeholders know afterwards what happened to their feedback. The involved level is one step further. So you're involving people. You're actually directly involving people with lived experience throughout the research process, to ensure that public concerns and aspirations are consistently understood and considered throughout the entire research process. And a good example of this would be advisory committees. That's where you bring people in to throughout the research process to give their input. And still the decision making does lie a lot with researchers, but there's more involvement throughout the process. And this, an example of this would be in falls prevention study. Caregivers of aging parents whom had experienced falls served as patient caregiver representatives on the project's data safety monitoring and board. And so these representatives were able to serve in this capacity, offering their interpretations of benefits, risks, and data analysis from a lived experience perspective. Now, collaboration is the level in which I'm a huge proponent of, but it requires a little bit more resources and time. This is where shared decision making, this is where you actually have people with lived experience on your research team and helping to co-design everything from setting priorities, looking at the research question, the study design, the data collection, all of that, bringing people together. And so this takes a little bit more time and resources. There are investments around relationship building and trust, and ongoing dialogues around power and making sure everyone feels safe. But there's been some great examples of patients as co-researchers on teams. In a mental health study, they had patient co-researchers and community members, and they helped craft the study name and the materials in order to reduce the potential stigma and to reframe the goal of the study as a movement towards emotional well-being versus away from mental health challenges. So in having people with lived experience on the research team, it actually helps improve recruitment of study participants, and it also meant greater acceptance of the study itself by the community. In another example, in a chronic pain study, there was an initial survey tool that was lengthy and it was going to be administered on the phone, and so patients, co-researchers on the study said, wait a minute, this is too much. And so they actually helped shorten and redesign the tool to self-reported, self-paced tool, and that actually helped get greater participation and ease of participation for people with lived experience. And the final one is user-controlled research. And this is actually where the entire research process of the project is in the hands of people with lived experience. And so all decision-making is with people with lived experience. And some people, what does that look like? Well, we actually have an example here in Manitoba. It's really cool. A mother of a child living with Hirschsprung's disease actually had started a social media campaign called Shit Happens. Sorry about that, but that was the name of the campaign. And it was she created this online community using Twitter and Facebook and a personal blog to support families living with the disease. And she then partnered with clinicians and researchers And together as a team, they started working to understand the knowledge needs of patients and caregivers in the community related to the day-to-day management of Hirschsprung, as well as the knowledge, and with the clinicians and researchers, they were also looking at the knowledge needs of pediatric surgeons. So it was great because patients were actually directing a lot of the research in this regard. So it's important taking in all this information around, oh my goodness, what level of involvement should I involve? You can actually involve people with lived experience at different levels, at different parts of your research process. So if you commit to, say, perhaps you want to do a priority setting using the James-Lind Alliance, which is a priority setting type of approach at the beginning to make sure that your research question is actually people with lived experience are really wanting this. So you can do that, and then you can move on throughout your, maybe as your KT stud, you want to use a different type of involvement strategy. So it's important as a research team to assess right off the bat, internal expectations. So understanding what the research team believes people with lived experience, what extent they believe that people will improve the outcome of the research. Understanding what, even in your research grant, there may be a minimum required level of involvement of people with lived experience. Funders more and more want to see that you are involving people with lived experience, whether it's in the priority setting phase, whether it's actually as collaborators, knowledge users, as co-researchers on your team. So better understanding that too. And then what extent does the research team believe what might be the potential for people with lived experience to influence the decision making, understanding where there's opportunities throughout your research for people with lived experience to actually have some shared decision making and influence the decision making. And it's good to have those open and honest conversations right off the bat to better understand what approach or involvement technique you might want to use later on. And then what resources are available, right? We want to think about things like compensation for people with lived experience. We want to think about everything from transportation, caregiving, and so on, that we can involve a diversity of voices, right, that may not have traditionally been involved in health research in the beginning. And in conclusion, one of the things that we're working on at CHI is using a trauma-informed intersectional analysis, which is a little bit, it's a lot to think of, but one of the big things that we want to think about too is that as researchers, we have to the importance of reflexive practice before you even begin to engage. So thinking about your own personal values and experiences and interests and beliefs and political commitments around in the health area that you're researching, and thinking about all of these things as you begin to engage with people with lived experience.